Hello, Dr. Simone. How are you? Uh,
I'm very well.
I'm here with Dr. Simone Dorsch. Dr. Simone Dorsch comes from Australia, and we are going to see her in person next November. And I'd like to, at first to introduce Dr. Simone. She has a bachelor degree in physiotherapy from the University of Sydney, as well as a master's degree in neurologic physical therapy and a doctorate in philosophy from the same university. She has been a lecturer at the Australian Catholic University for 13 years and has over 30 years of clinical experience in stroke and brain injury. She has won several awards, including the Australian Postgraduate Award and the ACU Vice Chancellor's Award for the Excellence in Teaching and Learning. In addition, throughout her career, she held several honorary positions in the Australian Physiotherapy Association, specifically as a chairperson on the Neurology Committee. Currently, as well as teaching at the university level, she's a director and one of the main contributors to the Stroke Ed collaboration, presenting stroke education workshops including evidence-based rehabilitation for lower limb skills after stroke, a 3-day workshop taught nationally and internationally, evidence-based rehabilitation for upper limb skills after stroke, a 3-day workshop taught nationally and internationally, 1,000 repetitions a day, a 1-day workshop taught nationally and internationally, the coaching workshop, a 1-day workshop taught nationally, and the balance workshop, a 1 or 2-day workshop taught nationally and internationally. So it's an honor to be here with you, and I would like to thank you so much on behalf of the Abrafin board for your kindness and availability to have this talk with me about some themes that will be addressed in your course to be held in São Paulo from November 16 to 18, promoted by Abrafin. Okay? So,
Thank you very much.
first of all, tell us about a little bit about Stroke Ed collaboration.
Yeah, so the Stroke Ed collaboration started as a group of colleagues, and we started presenting together. The oldest workshop we have actually is the one that I'm coming to Brazil to teach, the evidence-based retraining of upper limb skills after stroke. And that has run hundreds and hundreds of times all over the world. And it was developed primarily by Carl Scher and Annie McCluskey, so one physiotherapist and one occupational therapist. And then all of us that present into that workshop have also contributed content to that workshop. So the mission of Stroke Ed is that therapists everywhere are using evidence-based rehabilitation to optimize the outcomes of the stroke survivors that they're working with.
So this everything is from Australia, and you teach this workshop in which countries in the world?
Well, the upper limb workshop has been taught. It has been taught in South America, in Chile, and in Mexico once too, in many places in Southeast Asia, in China, in Korea, in Malaysia, in many places in Europe, in the United Kingdom, in Ireland, in Denmark, in Germany, and obviously across Australia. It's been taught many times in all over Australia as well.
And now for the first time in Brazil.
Yes, it's very exciting.
So, thinking of this, stroke is a worldwide problem and has apparently become more frequent in recent years. Do you notice that this too? Because in my clinical practice, I think that it's a true. What do you think about that?
Yes, I think all the statistics show that that is true, and that we have an increasing prevalence of stroke, and that there's an increasing number of stroke in younger people because of increasing lifestyle factors in younger people. as well. So in Australia, it's 1 in 6 people will have a stroke, but there's some countries where it's 1 in 4. In Sierra Leone, it's 1 in 4 people in the population will have a stroke. So yes, it is an enormous problem globally.
And so it's something that we need to be prepared to face. And
yes,
that's why I think it's so important you come here in November and we all participate of your workshop. Well, and that mainly because establishing a correct diagnosis of the dysfunctions presented is fundamental for effective treatment. In this context, what assessment tools do you recommend for clinical practice?
I think what is really critical to us is an assessment that is very much based around an analysis of what's the contribution of the impairments that somebody has. So if we're thinking about really analysing their movement problems, obviously having some kind of objective measure of performance, but I think really the most important objective measures that we take are at the level of activity. So some kind of measurement of upper limb activity, and I think that probably should differ maybe according to how disabled somebody is. So the motor assessment score, for example, or the motor assessment scale, is quite useful for people who have a very disabled upper limb. But for people who have better function, I think any of the good objective measures like the box and block test or the 9-hole peg test are a very good reflection and very sensitive to change as people's coordination and their fine manipulation improves as well. But I think what really needs to underlie our intervention is a very thorough analysis of what impairments the person has. And I think in stroke, that's very important because I think people's understanding historically of what are the important impairments is not very accurate often. There's often people believe that a lot of the problems are tone and spasticity, where in fact the major problems are lack of strength and lack of coordination. And that's good news because these are the things that we can make a difference. We can really make a big difference to these things.
Yes, you're right. And this is so important because if we don't diagnose correctly, we cannot treat. What are we treating? And
yes.
when you say about the analysis of the dysfunction, this is fundamental because we treat the dysfunction. We don't treat the stroke. We treat the dysfunction. We need to know what kind of dysfunction we are in front of.
Yeah. We spend a lot of time in the workshop using videos and going through the analysis process and looking at what are the movement problems somebody's having, making a list of what the potential impairments could be, and talking about how will we test to work out what is the contribution of those various impairments. So that analysis assessment process is telling us what the intervention needs to be.
Yes. Okay. And now, of the territories affected by stroke, the middle cerebral artery is the most frequent, which makes the upper limb rehabilitation a major challenge. What are the greatest difficulties physical therapists face when recovering the function of the paralyzed upper limb?
Well, I think it's that exactly. It's the paralysis that is our biggest challenge. I think when people have some reasonable amounts of strength and they can move their arm, it's much easier to work out what their intervention, what their training can be. But when they have paralysis or severe weakness of their arm, that's when it's much more challenging to work out what training, what practice they can do and set them up with some repetitive practice if they've got very little muscle activity. That's I think our most challenging, most difficult job that we have.
Tell me if I'm right. I want to speak something and please tell me if I'm right. Because sometimes we see a patient do an incorrect movement, a massive movement, and we think that it's about spasticity, but perhaps the task I'm asking him to do is too difficult for him. So, yeah, is it true? Do you see
that's
that?
that's exactly right, Solange. I think there's a lot of movements that we see that are maybe what you might call compensations, that somebody can't do the movement, so they use all these other muscles in an excessive way, and that's interpreted as spasticity when it's actually really the main cause for that excessive muscle activity in the wrong muscles, if you like, is more to do with compensatory movements, and just because often we're asking them to do something that is too difficult for them to do. And I think our skill, and I think we are often very good at this, our skill as therapists is finding the right practice to meet the ability of the stroke survivor.
Yes, because sometimes we have to go back a little bit, and sometimes we need to go forward a little bit. And this, knowing this, is the science. Yeah.
Yes. Exactly. Yeah.
So, and speaking of science, finding. Oh no, not this. Do you consider neuromuscular electrical stimulation to be an important resource in the rehabilitation of the pelagic upper limb after stroke? When should it be recommended?
Yes. I think this is a good evidence-based intervention. I've actually been working on an update with some colleagues. The project is being led by Kate Scrivener. We're doing an update of the Cochrane systematic review, looking at the use of electrical stimulation after stroke. The results will be, not that new from the previous review, but what it shows us is that electrical stimulation has a significant benefit for increasing strength and also increasing activity after stroke. And I think it's the main time that we should use it is in very weak muscles, in muscles that have less than anti-gravity strength. That's the main role for electrical stim. But I think there's also a role for what you might call functional electrical stim, where people are using some electrical stim maybe on some weak muscles while they're doing some functional task practice as well too. But really, its main role is in the very weak muscles.
And I think that as the previous item we were talking about, I think that we need to address to indicate the electrostimulate in the right moment, and perhaps in the right muscles, because it's something that in the clinical practice you take a lot of time with just one muscle or a little group of muscles. So it has you must have a very specific goal, don't you think so, for electrostimulation?
Yeah. And I think really when you look at where there's research that shows effectiveness of electrical stimulation, it is done, the dosages are reasonably high, like it's usually often done for 30 or 60 minutes a day for 4 weeks. And really it's not realistic for us to deliver that during a one-to-one therapy session. So I think this is actually an intervention that we need to be training the stroke survivors and their families as to how to use it. And then that gives you the ability to cover more muscle groups too in that intervention.
Okay. So findings from neuroscience have brought various possibilities of intervention, such as mirror therapy, mental practice, and the constraint-induced therapy technique. Do you think it's important to integrate these techniques into clinical practice, or they are just useful for research?
No, I think we have clear evidence of benefit of these techniques, and actually in the workshop we have practical sessions where people practice mirror therapy, mental practice, electrical stimulation, because these are a very useful adjunct to our clinical practice, and we have evidence for them. We should be using them in our clinical practice.
And it's very important because people, in the case of mental practice, for instance, some people misunderstand what mental practice is. They do when you do mental practice, you cannot contract the muscle. You just do mental practice, and people make some mistakes. And it will be very useful for us that you enlighten this for us and have this training in all these techniques.
Yeah. We do cover that in the workshop and explain how to do it and get people to practice doing it. Yeah.
Okay, that will be fantastic. So the course is planned to have some practice training. How this will be done?
Well, we have like quite a few practical sessions where the therapists are practicing with each other on some of those interventions that they might be less familiar with, like mental practice and mirror therapy and electrical stim. We spend time talking through the principles of constraint-induced movement therapy, but I think really to learn how to do constraint-induced movement therapy, that kind of needs its whole workshop to itself as well, because that is a very specific intervention with a lot of detail, but we do talk through the principles of that. And then we have clinical sessions with stroke survivors, and I think that is a very important part of the workshop. Because we wanted to increase the numbers of the workshop in Brazil, those clinical sessions, the therapists will be working in larger groups than what we would often have. But the plan is to have, if we have 50 participants in the workshop, the plan is to have 10 stroke survivors, so that the therapists can work in groups of 5, and you would work with the same stroke survivor for one day and continue to see them a little bit the next day, and then swap, so that we try and change the experience that people are having, so that if in the first clinical session they're working with somebody who has a very, very weaker arm, that in the second clinical session they get the opportunity to work with somebody who's maybe doing more advanced coordination skills. So we try and provide that opportunity. And then we will have myself and Eleni Skiani, who will help to supervise those clinical sessions.
Okay. And the course has a big focus on evidence-based practice. Why do you think this is important?
I think this needs to underlie everything we do. In stroke rehabilitation, we now have an enormous body of evidence to inform our practice. I think there is no excuse, no reason for us to use outdated modes of therapy that have not been shown to be effective. I think, in fact, it is very unethical for us as therapists to be using interventions that are not evidence-based, because we have a lot of evidence to use now. And I think it's important, and we do talk through this a bit in the workshop, that we have some understanding of appraisal and knowing what is good evidence. But we must be using that evidence to drive our practice, because obviously that's how we will get the best outcomes for our stroke survivors.
And evidence is safety to the patients too. When we do an evidence-based practice, we're taking care of the safety of the intervention.
Yes.
Our bioethical principles speak about you cannot harm, but there is another thing. It's not enough not to harm. You have to make benefit. So that's one of the principles. There are 2 of the principles of bioethics. So it's important for us to have this kind of translation of the knowledge, because sometimes it stays too much on the research, and for us in the practice something very distant. And I think that this course will make things come together more easily. Don't you think?
Yes, and I think the whole really the focus of all of our stroke ed workshops is to inform people as to what the evidence is, but really to enable people to implement that evidence. So, to really know what that means for us in our clinical practice, and what are the strategies we can use for implementing that evidence, because it's often not easy to put evidence into practice. And that's what we're really trying to facilitate with our workshops, is people's ability to apply the evidence.
So finally, tell us about your experience with upper limb retraining after stroke workshops around the world, and what participants can expect as a result.
Well, I've taught the upper limb workshop a few times in Australia, but I've taught it more overseas, because I've done a sort of a teaching tour in Europe and the UK, where I travelled with Lauren Christie, who's an occupational therapist, and we did multiple upper limb workshops in a teaching tour. I'm teaching it a few times again in Australia before I come to Brazil. So the feedback that we get from the participants is that they feel very empowered in their upper limb rehab, and they feel that they have much better awareness of what the evidence is, and much better knowledge about how to do some of those evidence-based interventions that they might not have used, and that they feel that their clinical reasoning has much more structure to it. So they feel that they feel more skilled at going through that analysis process to really figure out what are the impairments that somebody has, and how they address those impairments.
Yeah.
So the basic feedback is that people feel a lot more confident and competent in their upper limb rehab.
That's what we expect too. And I think that I'm very anxious for this workshop, because I think that it will be historical for us. It's important for us to have this kind of high-level discussion, because our patients need too much our intervention, and we need to be responsible. We need to be ethical, and we need to go in the problem. We need to address the real problem of them, as with all the tools we have. So
yes,
I think it would be very good for us.
Yes, yeah.
So
yes, and I'm really looking forward to coming and seeing you in Brazil.
Are you anxious to know us?
Yes, I'm very much looking forward. I've heard a lot about Brazil, and of course in Australia we've had a lot of Brazilians come to Australia to do their PhDs, and we have a lot of, I know Pedro is very big in Brazil, so I think we've had some great connections between Australia and Brazil historically. I'm very excited about coming there.
Yes, that is. So I want to say to thank you again for your time, for being here with us, and I'm just please say goodbye for our audience, and we will finish here. Okay.
Looking forward to seeing you in Brazil in November.
Okay. Bye bye.